depression who just had electroconvulsive therapy and is still unresponsive. So remember that electroconvulsive therapy is used when the depression, the endogenous or psychotic depression, doesn't respond to the medication and is like a surgery. So the client need to give consent. The client need to be prepared like for surgery. And the client is going to have anesthesia, and the client is transferred posteriorly to an area to recover from the anesthesia. So it sounds more similar with the usual work of a nurse that work with surgical clients. And then the last is a depressed client admitted for suicidal attempt the day before. So obviously it is a suicidal client, which is not the usual type of client that is used to work the medical surgical nurse. So obviously based in this in those rules that we have been discussing for the delegation, the most appropriate client for this nurse is the client C, the client that is under anesthesia, recovering from the anesthesia after general anesthesia. If you want any explanation, if you disagree, please feel free to intervene. Next question. A client with Parkinson's disease and depression has been taking citalopram for a long time. We should know what is citalopram. It is an SSRI. It is a selective serotonin reuptake inhibitor. You should know the names of the most important SSRIs for Nclex. Nclex doesn't say in the question SSRIs, says citalopram, uh, paroxetine, fluoxetine, sertraline, citalopram. Probably those are the most common. Fluoxetine, paroxetine, sertraline, and citalopram. There is another is citalopram that is so similar that it's not going to be necessary to learn the other one. Those are the most commonly used. Uh, the the prescriber orders new medications, these 4 medications. Which of these 4 medications, which order should the nurse object, protecting the client, you know? And you have levodopa, encatapone, selegiline, ropinirole. The levodopa, the entacapone, and the ropinirole are dopaminergic medications, all of them used for the treatment of Parkinson's that don't have direct interaction with the SSRIs. Selegiline is a monoamino oxidase inhibitor type B, which is also used in the treatment of Parkinson's, but interacts with the SSRIs, producing hypertensive crisis. So, MAO inhibitors should not be given together with an SSRI because is not good for the clients. It's very risky for the client. More than that, clients that are taking either MAO inhibitors and are going to be changed to citalopram should wait 2 weeks for a washout period to totally eliminate from the system the MAO inhibitor before starting the SSRIs. It is a classical pharmacological question. You should have previous experience in your pharmacology class of this combination, monoamino oxidase inhibitors and SSRIs. And again, you need to learn the main representatives of those groups. In the Nclex, they don't say monoamino oxidase inhibitor. They say phelnacine, selegiline. At least learn these 2, phenelcine and selegiline. Okay, the others are tranylcypromine and isocarboxacid. But the most important, try to learn the most important, and probably are the ones that are going to be used, selegiline and phenelcine. Feel free of asking any questions or any doubt in relation to the question that we are explaining. The nurse is carrying out an interview for a client with suspected esophageal cancer? Which of the following questions is indicated in relation to this condition? Hmm. Have you noticed blood in your feces? What type of food are you presently eating? Did you suffer of gastric ulcers? Have you experienced left lower quadrant abdominal pain? Esophageal cancer is an obstructive cancer of an structure that is tubular and is the food pipe, the footway between the mouth and the stomach. So the only function of the esophagus is the transport of the what we ingest orally from the mouth to the stomach. It's a tube, and the cancer tends to grow in the walls of this tube. When there is a tumor, a mass growing in the walls of the tube, obviously the main symptom that is going to appear is dysphagia, is obstruction to the passage of the food. Of course, the food that is going to have first problem to pass are the foods that are voluminous, are bulky and tough. The most common initial symptoms is with meat. When people eat meat, okay, take a piece of cut a piece of meat, they chew the meat, but the meat is not to break down. It's going to continue forming a mass. And then when the meat, okay, arrive in this narrow space, get stuck there, and the client is going to experience this sensation of that something is stuck there, even can produce a spasm and pain, and even can regurgitate, okay, the food. Uh, Probably at the beginning, the liquids are going to pass without problem because liquids can pass, or food that very soft can pass even existing an obstruction here. So obviously, the best question that you can ask in this case is what type of food are you presently eating? Talk to me about how are you dealing with the different type of food. Probably the client is telling, well, I can eat practically everything, but I cannot eat meat because then I do not have this sensation of stocking of the food. But I can have soups, I can have purees, I can have liquids. So this kind of conversation is going to give you an idea in client with esophageal cancer. If this cancer starts bleeding, the blood is going to accumulate in the stomach and is going to pass to the intestine. And after many hours and many feet of length of the GI tract that that has a very long number of intestinal loops, this blood is going to appear many hours later as a terry black stuff, gooey stuff that is the melena. Yes, the melena. So the melena never looks like blood. So asking a client that doesn't know the meaning of melena, okay, terry black poo, asking if they have blood in the feces make no sense. Is translate ignorance of the nurse asking that. The nurse should know that this is blood, digested blood, but the clients don't know that. So you can ask how is you pooing to see if the tumor is bleeding, although these kind of tumors don't bleed frequently, are more producing obstructive symptoms than bleeding. When there is blood, real blood with the poo, it's called hematochezia. He, con E. Hematochezia, okay? And this is seen when the bleeding lesion is at the end of the GI, generally in the colon. So, for example, clients with, let's see, colon cancer, diverticulitis, hemorrhoids, etc., can have hematochezia, which is blood in the feces. But the bleedings that occurs in esophagus, stomach, and duodenum, the upper GI tract, don't appear as blood, appears as melena. And a client doesn't relate the black stuff with blood because it's totally different. Gastric ulcers in the stomach have nothing to do with esophageal cancer. The most common cause or risk factor for esophageal cancer is alcohol and tobacco are the two more important risk factors for developing esophageal cancer. Sometimes appears just because bad luck. It's not. But gastric ulcers don't have relation with esophageal cancer. You need to remember, well, we covered that in the review of GI, that when a client suffer of chronic a gastroesophageal reflux disease, which has nothing to do with gastric ulcers, is just incompetence of the lower esophageal sphincter, the client can develop a precancerous, a pre-malignant lesion called the esophagus of Barre. Barre is the guy, okay, Barre's esophagus. Barre is a guy that described this metaplasia, this deformity, this abnormality of the mucosa of the esophagus when it's exposed to recurrent acid from the stomach in GERD. So recurrent GERD can produce Barre esophagus and could be a pro-cancer lesion. And the esophagus classically doesn't produce left lower quadrant abdominal pain. If you are able to understand what is left lower abdomen, you know that in the left lower abdomen, what you have is the colon. What you have is the descending colon, the sigmoid columns, yeah, and is the area, for example, of the diverticulitis. This is, you divide the abdomen. This is the belly button, no? This is the left lower quadrant. Here you have the descending colon and the sigmoid colon and the rectum. Here you have in women the left ovary and the left fallopian tube. But basically, those are the most common organs that produce pain in the left lower quadrant. Okay, the left lower quadrant. Okay, so dissected the question to obtain the maximum information and education of the question. Next question says, which of the following the nurse expects to palpate during the assessment of the heart? What could be palpated in the assessment of the heart in normal clients? Okay, which of the following there's expected to palpate normally during the assessment of the heart? So a bruit in the second intercostal space. Bruit cannot be palpated. Bruit is an auscultatory phenomenon. So it's a nonsense. You cannot palpate a bruit. You can palpate abnormally a thrill, okay, in some intense murmurs, but not a bruit. A S3 in the fifth intercostal space. And S3 is also an auscultatory phenomenon, is auscultating with a stethoscope, so it's a nonsense. Palpating a thrill is not normal. So palpating a thrill in the second intercostal space could be found in a pathology of the aortic valve if it is palpated at the right of the sternum, or the pulmonary valve if it's palpated in the left of the sternum at the level of the second intercostal space. But a thrill is not normal to be palpated in the precordium. And the question is referring to normal palpation and assessment. A point of maximal impulse in the fifth intercostal space with mid-clavicular line, okay, we could complete that, is normal to be palpated. And this should be the answer. Remember that the apex, the heart has a pyramid, okay, or cone shape, and the apex, the tip of the heart is formed, is represented by the left ventricle, and in adults, in normal adults, very constantly, this tip should be in the fifth intercostal space, counting from topper to down, at the level of the mid-clavicular line in this intersection. Any displacement of this um, point of maximal impulse is called, that can be palpated in, especially in thin individuals. Any displacement, okay, to the left and down suggests enlargement of the heart, cardiomegaly. In children, it's a little higher in the fourth intercostal space. Also can be in this position in pregnant women at term, okay, at the end of the pregnancy, because the enlarged uterus can push the heart upward. And what else you can know about this? Okay, so this is also the place where you auscultate the mitral valve. And you know that the mitral valve is the one that produces the S1. So S1 is better auscultated there in the fifth intercostal space. And any abnormality of the mitral valve, like for example, murmur, okay, uh, uh, should be better auscultated there in this same place, in the fifth intercostal space. When you have a client that is difficult to palpate the point of maximal impulse, you can turn the client to the left side and then explore through palpation for this PMI, point of maximal impulse, and you can find it much more easily. This is information that you can be tested. Is information of assessment. Remember that we registered nurses should know how to do assessment, because this is one of the privileges that give us the licensure of registered nurse. Sorry. Okay. The nurse is preparing to administer an oxytocin infusion to a pregnant client to initiate, to induce labor. Which of the following is needed to administer this drug? Magnesium sulfate, infusion pump, reflex hammer, calcium gluconate, Doppler stethoscope. Okay, obviously, we need an infusion pump to administer oxytocin, such a delicate medication. And we need to evaluate how the fetus, specifically the fetus heart, is responding to the in more intense contractions induced by the oxytocin. Uh, the calcium gluconate and the reflex hammers is for the administration of magnesium sulfate. The if the oxytocin is producing too much contraction, so contraction that are more frequent than every 2 minutes or lasting more than 90 seconds, no, this is called tachysystole. What need to be done is to stop the drip. Okay, tachysystole, okay, is to stop the drip, okay, is the intervention, doesn't require a specific antidote. Uh, uh, for the magnesium sulfate is that we need the calcium gluconate as antidote in case of overdose, and the reflex hammer to evaluate um, if the early manifestation of magnesium toxicity through the exploration of the deep tendon reflexes. The question can be changed, but you need to administer, instead of oxytocin, magnesium sulfate. I can change the question and similar, okay, options. Next question. The unlicensed assisted personnel, I mean the CNA, informed informed the nurse that the client with COPD is having breathing difficulties and cyanosis after assisting the client to ambulate as ordered. After going to the client's room, which of the following interventions should the nurse carry out first? Administer oxygen through the mask at 2 liters per minute. Sit the client in tripod position. So auscultate the client's lungs and read pulse oximeter. Call the rapid response team. So obviously, what is important in this question is the word first, which is requiring a chronological, okay, prioritization. The scenario is a patient with a chronic condition that produce breathing difficulties and even cyanosis. So breathing difficulties and cyanosis are not desired, are not normal, but are frequently found in patients with COPD, especially after exercising. These kind of symptoms tends to improve when the client rests after the exercise. Obviously, the RN is counting on the information given by the CNA because the RN has not seen the client, and then should go to the client's room to evaluate the degree of severity of what is detected by the CNA, and depending on the diagnosis, to decide what to do. So I have here one intervention, so what to do, another intervention, another what to do, another intervention, another what to do, and I have an assessment. Obviously, the assessment is the first that we need to do because the assessment will tells us if this distress is expected, as I said, and common in clients with COPD when they do exercise, or if, by the contrary, the client is presenting a more severe decompensation that requires seating the client, giving oxygen, and calling even the rapid response team. Here applies that in this scenario, first assessment before deciding what to do, because the nurse doesn't know really what is happening. Is only counting with what the CNA is referring. Remember that not always assessment is the first option. There are situations in which in the question, the unregistered nurse obtain a valid, a dependable, reliable information given by the own questions. And based in this assessment that is already present in the question, that is reliable, the nurse needs to take a decision, an intervention, if it is a priority. So, for example, a client that is arriving to the ER with symptoms of tuberculosis or meningitis, the first to do is not assessment. The first to do is infection control to prevent the dissemination of this possible infection that is contagious that is arriving. And then we can put an assessment as a distractor when what need to be done in those cases is placing a mask on the client or isolating the client, etc. The other classical question in which assessment is not the first is that the question described that is arriving a client victim of an accident, severely injured, with multiple wounds that are bleeding. So it's a guy that arrived with multiple wounds that are bleeding, and the client uh, is is you anticipate that probably is in shock, and the clients need to be assess the airway to see is open the airway, and after that assessing the level of consciousness and the neck, immobilizing the neck, etc. And they ask you what you do first. Do you assess pupils? Do you assess airway? Do you assess respiration? Do you assess blood pressure, or you put on PPEs? First to do is not assessment. The first to do in this case is to put on PPEs. You cannot assess this client without PPEs because the client is full of body fluids, blood in this case, all over. So those are situations and questions where you need to be very clear that not always assessment is the first. The nurse received an order of inserting a nasogastric tube for an unconscious client. In which position should the nurse place the client? Okay, it is an interesting question. When you have a client that is conscious, okay, and is going to be inserted a nasogastric tube, the higher that the client is, the easier the introduction of the tube is going to be. So having the client at 45 or 90 degrees, okay, is going to make very easy to introduce the tube because the gravity force is going to help you to advance the tube from the nose to the stomach. But when you have a client that is unconscious, keeping those positions are difficult. And the problem is that in unconscious clients that have not established the airway, is very risky, the manipulation of the throat and the stomach, because the client can vomit, and when the client vomit, can aspirate. In those cases, for safety, these kind of manipulation should be done with the patient in flat position and in lateral position. If a person that is unconscious is in this semi-fowler position and vomits, produces a vomit, the vomit is going to easily be aspirated. But if a client in this position vomits, the vomits easily is going to go out with decreased risk of aspiration. For that reason, in this case, because the client is unconscious, the best the best position of this for giving here to introduce the nasogastric tube to prevent aspiration in case of vomiting is the flat lateral position. This is the position in which the client that is having an endoscopy after sedation is a client that is unconscious, is sleeping, but not intubated. When have a gastroduodenoscopy, an upper GI endoscopy is placed also, yes, for the same reason in left lateral. The left lateral is better than the right lateral because in left lateral, the stomach anatomically, yes, anatomically is going to have this position. So when the tube enters, is going to, by gravity, you know, be directed to this cavity that is from here where the liquid of the stomach is localized. This is also the position to practice a gastric lavage to a client, for a client that is unconscious because ingested an overdose of sedative, for example. So having the client in left lateral with decrease the risk of aspiration. This is the position for endoscopies, the position to introduce a nasogastric tube, the position for a gastric lavage in a patient that is unconscious and cannot control the protective reflexes that prevent aspiration in case of vomit. But if the client is conscious, it's much more easier and collaborates and can, when we are conscious, the risk of aspiration decreases. You and me, have vomited in our life, but we were conscious and we didn't aspirate. When you are conscious, okay, it's difficult. It's not so easy to aspirate, but being unconscious is very easy that if we vomit, aspirate. That's why it's different, the position. I hope that my explanation um, make you understand that, because it's not for memorization, it's for understanding. The hospice nurse is visiting a terminal client at home, which finding requires follow-up. Obviously, follow-up means what is wrong, what is not correct, and need intervention or need assessment. Each time the client presented pain, is terminal. The spouse, sorry, there are many typos here. Okay, okay. The spouse administered painkiller as prescribed. I need to transcribe those questions when I find the question interesting, and sometimes I commit a lot of mistake. I do that very fast. Obviously, there is no problem. We are generous, we are liberal in the administration of pain medication for clients that are terminal in hospice, even being at home. Even when they have depression of the respiration, but have pain, we still give the pain medication that usually are opioids because, the purpose is to understand that the client is going to die, but is going to die without pain. Is going to die comfortable. So no problem, no need of follow up of this. The spouse limits visitors to avoid making the client too tired. This is also correct. Okay, this is also correct. This morning, today, I was discussing with a student who had a question similar to this. The question, was if a nurse is acting correctly when limiting visitors and phone calls in certain type of clients. And the answer is yes. Even can be a doctor's order. For example, a client that need absolute rest, like a client, I don't know, with a brain hemorrhage, with an aneurysm and a brain hemorrhage that requires a lot of rest and avoid emotions and etc. Probably would have limitation of visits and phone calls. A client with tetanus, which is a condition that we don't see in America thanks to the vaccination, no matter the new fad that to oppose vaccination, we don't see in America tetanus like I saw in my country because people are vaccinated. Okay, needs absolute silence and no visitors and phone calls. Sometimes there are clients like this, a client that is dying, and then maybe the people wants to visit to say goodbye, to demonstrate that they take care, etc., and it is appreciated. But the client is too sick, the client is dying, the client is not in condition of receiving visits. So it is correct. The spouse insisted on the client eating the food provided. And here is the problem, probably. Let's see the last. The spouse placed a fan in front of the client's face to make him breathe better. This is correct. Please notice that this statement is very common in Nclex. Using the convection action, so the air that is blowing in our face, in clients that have respiratory distress, a part of the other interventions, no, as part of the number of interventions that can be done for respiratory distress is okay, is a good intervention, has demonstrated that we don't know exactly why, produce a lot of comfort for the client and improvement of that. So the problem is C. Has been demonstrated that when we are dying, when we are in the process of death, okay, the progression, deterioration, and death, the GI system slows down and even paralyzes. Uh, Forcing the client to ingest food will produce nausea, abdominal distension, especially stomach distension, nausea and vomits with all the discomfort that it brings. Bloating even can produce diarrhea, requiring frequently changes of diaper, etc. All of the is going to bring discomfort to the client. Clients that are in the process of dying generally are not hungry. There are several substances produced during this process, like the tumoral necrosis factor, etc., that produce intense anorexia. And the client has been classified as terminal, so it is part of the process. A part of that, the the morphine, the opioids used for the treatment of the pain also takes the appetite of the client, also produce anorexia. Even the thirst is not experienced the same way for in clients that are in this process of dying. So it is not indispensable the hydration. For clients' comfort in relation with the hydration, with the thirst, what is convenient is to keep the mouth clean because the saliva production decreases and so mouth care and moist, okay, with water-based lubricants, but not forcing the clients drinking fluid if the client is not requesting that. And the same apply for the food. So we need to explain there are some cultures like mine in which we consider that food heals and food is important and food is necessary. And if we love a person, we need to force this person to eat. And it is a mistake in this scenario in case of terminal uh, uh, patients that are dying. So we need to educate this spouse that it is not convenient, it's not nice for the client to be forced to eat when they don't want to eat, period. And that's it. It is a concept. That's the reason for which in hospice, IV hydration, enteral feedings, nasogastric or PEG tube, or TPN is not part of the hospice treatment, is not included. The nurse working in the ER receive for client. Which client should the nurse see first? The question of prioritization. We have a 9-year-old pediatrics, a 9-year-old child with a deep laceration on right hand with tendon exposition. So obviously it requires attention, but it's not really an life-threatening condition. It's a problem of risk for disability if it is not properly managed by the hand surgeon. A 12-year-old male with second-degree burns in the lower half of the abdomen. The lower half of the abdomen is far from the airway that are the burns that are priorities. And second, the amount of body surface area that have been burned is not extreme. 12 years, okay, the anterior part of the abdomen is the inferior part of the anterior abdomen is 9%. 9%. It's not a extensive burn, so it doesn't look to be the priority. 16-year-old with left humerus fracture and radial pulse not palpable. This is more serious because the fracture is going to produce a compression of the humerus, probably the brachial artery, the humeral artery, and for that reason, the blood is not passing, is not circulating to the extremity. This can produce an irreversible damage of the upper extremities, the upper extremity, and it could be the priority in these clients until now. In the last is a 5-year-old found unresponsive in a swimming pool with dilated, unresponsive pupils. So this client is dead because was found, okay, drowning and has already unresponsive pupils. So this client probably is not going to require any intervention. So obviously, number C or letter C is the best answer of this question. You need to be careful if in the Nclex they give you a similar situation like this, but a person that has been drowning in frigid, in very cold water, because those clients are hypothermic and the hypothermia prolongs the time for possible resuscitation. So in the scenarios when we have a person with cardiopulmonary arrest, even with dilated pupils, but the client is cold, is very cold, is frigid because has been immersed in cold water, so has hypothermia, resuscitation should be attempted, even if we don't know the time of the cardiopulmonary arrest. The rationale for that is that those clients can have the brain function preserved and have been demonstrated by evidence thanks to the hypothermia. But generally, when a client has evidence of death, brain death, and is in cardiopulmonary arrest, and the time of the cardiopulmonary arrest is unknown, uh, there is no a necessity of initiate resuscitation because we assume that the brain is already dead. Palliative care can be defined as which treatment address to cure a disease or health effect. Obviously, this is not the definition of palliative care. Okay, it is a curative care limited for only terminal or end of life health condition. Even if in the common jargon of nursing, we tend to use the term palliative care for clients that cannot be cured, cannot be recovered, and are going to die soon. It is not the same. Clients that are terminal and in the process of end of life, uh, they can receive palliative care, but it's not exclusive for those clients. In reality, the type of care that should be defined that is used for clients that are dying should be comfort, comfort care, comfort care. Okay, the palliative care is any care oriented to improve. This is the synonym, the symptoms of any disease. So it's not curative. Is used in diseases that don't have cure generally, but improve the symptom of the disease. For example, if we have a client with end stage renal disease, this is a client that is not placed in any form of dialysis, is going to die. But this client can be kept alive for years with dialysis. For example, hemodialysis. Hemodialysis is an example of palliative care. Notice that it's not curative. Okay, the only curative condition here is the kidney transplant, but it is considered a palliative care. It's a palliation, okay, or improvement of the symptoms of the disease without curing the disease. There are many conditions that are treated with palliative care. A patient with a very enlarged heart, with a severe form of cardiomyopathy and heart failure receiving treatment, it is a palliative care. And the client doesn't need to die. The client can live, okay, for a long time with this kind of palliative care. So it's a refining, a tuning of the concept of palliative care that wrongly has been used as a treatment of clients that are going to die very soon, at least in the next 6 months, which is more appropriate to use the term comfort care. For example, a client that has been declared end of life or hospice with end-stage renal failure is not going to have dialysis. And dialysis is a form of palliative care. The home health nurse is dispensing a safety evaluation of an old client's house, which finding requires follow-up. The air AC, the air conditioning, is set at 75 Fahrenheit during summer. It is a reasonable temperature. The stairs has a non or no skid carpet. In the stairs is better to have carpets than not having carpet. Stairs benefit in the prevention of accident with carpets. Those are wall to wall, carpets. The carpets that are from side to side. So this carpet, a non-skid is to prevent slip and falls. So carpets are good. What is not good are the mats, loose or thrown mats, and even those small how you call that? Yes, um, mats and etc. But the carpet, wall-to-wall carpet, and especially in stairs, prevent uh, uh, slip and fall. So it is correct. The bathroom has safety bars and an electrical space heater, an cable, electric cable. Let me clarify this because it's very messy. Okay. An electric, so we rule out this and we rule out this. So we need to work with the last two. The bathroom has safety bars, those bars that we put on fixed in the walls to hold while we are showering or transferring, and electrical space heater for warmth. And the other is an electrical cable is tack, with tackled to the wall baseboard. Okay. Uh, Notice that if we have a room, and let's see, the uh, outlet, the electrical outlet is here, and the TV, for ABC reason, is here. So for the TV, uh, and obviously the TV has an electrical cable. The electrical cable can be, tackled or fixed to the baseboard, or the wall in this way, and it is safe. So this is correct. So the problem in this option is that the client is having in the bathroom an electrical device. You know that electrical device accidentally can become wet, and then the electricity can be transmitted through the water and can produce an electrocution. So this is a safety issue that requires follow-up, requires intervention. Select the adequate food items for a client with dysphagia. Uh, Seedless grapes, anything that has this round shape or cylindric shapes, definitively are risk for aspiration. So grapes is not good. Pudding is okay. Pudding is okay. Different forms of puddings are okay for clients with dysphagia. Mashed potatoes also are okay. But banana is not okay. The experts, you can find that in the books. Experts say that banana, the fruit, if you have mashed bananas, is okay. If you have previously mashed bananas, is okay. But eating bananas is going to produce fragments with the shape that can lodge in the trachea and produce obstruction. The banana has a cylindrical shape, no? A cylindrical shape, no? So a banana has a cylindrical shape. And second, uh, when the banana is chewed, produce like a gooey mass that can easily get lodged in the throat. The experts say don't give banana unless it is previously mashed. Scrambled eggs is also another item that is no good by the expert. You can find that, they have literature of that, okay? What is called the step one dysphagia diet. Uh, is another because the scrambled eggs produce those clumps, okay? Those clumps of coagulated protein, that is the scrambled eggs, that also have these shapes and favor aspiration. Thickened liquids like lemonade or whatever is okay. So obviously, with the exception of the grapes, the banana, and the scrambled eggs. And please, if you didn't know that, educate is based in evidence, is brought from some peer review information. Uh, the right answer is pudding, mashed potatoes, and thickened lemonade. I can find quickly this information. Is nutrition, I think. Okay, here is. Okay, this is called dysphagia level 1 diet. I don't remember the institution that regulates that, but it's a government, it's an official institution, NDD, national, no sé qué, de falla, classify the food in dysphagia level 1, level 2, level 3, irregular food. Uh, of course, it is from more severe to less severe. Uh, Generally, what the Nclex is concerned is when you have a client convalescence of a recent stroke, or a client with a acute crisis, or this a crisis of I don't know, Guillain-Barré or myasthenia gravis, in which the client has a severe form of dysphagia. So what I suggest you to learn is to educate yourself, and I have the reference, okay, of this. You can find that in internet, okay. You can find that in the National Institute of Health, NIH.gov. Okay, this is the dysphagia level 1. Sit the client at 90 degrees, avoid distraction, use thickened fluids only, avoid straws. Don't use straws. Permitted food, pureed breads, smooth puddings, custards, yogurts, and yellow. Pureed fruit as well mashed bananas. As well mashed bananas. Pureed meat, souffles, well moistened mashed potatoes, pureed soups, pureed. Those are mechanically modified and pureed foods that are used in dysphagia. Foods to avoid: crackers, breads without being pureed, no? Cookies, cakes, or pastry, tree nuts, peanuts, any cereal with lumps. So oatmeal, oatmeal is a no-no. Um, Bananas, grapes, and any whole fruit. See that? Non-pureed meats, beans, or cheese, scrambled, fried, or hard-boiled eggs, non-pureed potatoes, pasta, or rice, non-pureed soups, non-pureed vegetables, hard or chewy candies, sticky food like cream cheese, marshmallows, and peanut butter. I suggest you to have this information in your memory, because it is nursing. It is what should be tested in English. It is nursing, and is I found that frequent in different type of question. Remember that English has many versions of the same topic and the same questions. The nurse is evaluating a client 2 weeks after renal transplant, which finding requires immediate follow-up. So again, follow up, something is wrong. and it's immediate, so something serious. It is 2 weeks after renal transplant. Urinary output 105 milliliters each hour. White blood cells count 11,500. Temperature 101.4 Fahrenheit. Positive red blood cells in urinalysis. The client has just a kidney that doesn't belong to the client being connected in the client's pelvic, okay, to the iliac artery, the iliac vein, and the ureter is going to have been connected to the urinary bladder. Of course, having so recently, this procedure is expected to have red blood cells. Notice that is a, a, a connection here. No, it is a stitches, etc. in the process of healing. A positive red blood cells are expected after a renal transplant, because the urine that is produced here is going to mix with the blood of all those cuts and stitches that the client has. The process of healing and formation of a scar, so this process of healing of wound requires inflammation. And each time there is inflammation, you are going to have leukocytosis. When the inflammation is expected, the inflammation is in the process of healing, is not associated with infection, the leukocytosis is mild to moderate. If there are infections, the leukocytosis tends to be more exaggerated. But I expect a process of inflammation after a kidney transplant, because there is a lot of healing and immunological adaptation to the transplant. So this mild elevation of the white blood cell is expected. When the client have a recently transplanted kidney, the new kidney is going to take a while, is going to take a time to regain the capacity of concentrate the urine. We have our own kidneys, and our own kidneys are able to urinate between 30 to 60 milliliters per hour. Why? Because our kidneys can concentrate the urine. When we are short of water, we decrease the amount of urine produced per hour to 30. But when it is like today, rainy, cold, and we are drinking liquids, coffee, etc., we pee more frequently, we increase. So there is a change in the amount of water that is retained or eliminated, and it is what is called the capacity of concentration of kidneys. But a recently transplanted kidney have not this capacity, and the average minimum urinary output until recovering the capacity is around 100 milliliters per hour. So this polyuria, this um, lack of capacity of concentrating of the urine is expected in a recently transplanted kidney. So definitively what is not expected, it is this important fever. Why is concerning? Because remember that this client is taking immune suppressors to make the body tolerate this transplanted kidney. And if there is a fever, okay, we should be in the need of evaluating why the fever. Is the client catching an infection because immune suppressed? Or maybe the client is rejecting the kidney, which also produces fever, and we are impressing of the rejection. Whatever, it is not expected, and that's why it requires follow-up, requires more assessment and report and interventions. But the other findings are expected in a recently transplanted client, in a recently transplanted kidney. Diabetic client with admitted in the ER for probable perforated appendicitis so it is already complicated, is going for an abdominal CT scan with contrast. Which of the following findings required immediate report? BUN 28. The BUN is elevated. The BUN normal is 10 to 20. In the Nclex, now you have the normal value, but here is elevated. I tell you this elevated because 10 to 20 was the normal value of this. The elevation of the BUN can translate or renal failure, okay? Renal failure, which is not rare in clients with diabetes, with long-standing diabetes, and or can translate dehydration. Either one, either one, the use of um, of iodine contrast, okay, because the client is going to use iodine contrast in somebody with renal failure or dehydrated is contraindicated. If what the client has is dehydration, should be hydrated before using the iodine contrast. Why? Because the combination of dehydration and iodine contrast is going to precipitate renal failure. And if the client has already renal failure, the iodine contrast is going to worsen, is going to make more severe the renal failure. So this is concerning and need to be reported. White blood cells in 16,000 are expected because the client has a perforated appendicitis and has not interaction with the iodine that is going to be administered for the CT scan. The hemoglobin A1C very elevated translate a lack of well control of the diabetes in the last 3 months. This lack of well management of the diabetes is not going to contraindicate or interfere the use of iodine as contrast in the client. So it has nothing to do. But the metformin cannot be given together with iodine, and the client received recently metformin. The combination of metformin and iodine contrast can produce lactic acidosis, should be reported. The client had a barium swallow 2 days ago. When the client swallows barium to do a test in the abdomen, maybe the client 2 days ago has an abdominal pain, which was the appendicitis, and the doctor didn't suspect appendicitis, thought was an ulcer or something like this, and ordered a barium swallow. After this barium swallow, and along 7 to 10 days, inside the intestine and inside the GI, there is going to be a remnants, okay, of the barium. It's going to be residues of the barium that are going to interfere in the evaluation of the CT scan. For that reason, this must be reported if you found this information, because it's going to make the radiologists and the doctors understand why those weird images that are present in the study. What the last one that the client is NPOs injected, there is no problem, doesn't need to be reported because it's okay to have an NPO status to have a CT scan of the abdomen with contrast. So this is the best explanation of this question. In which situation exists a violation of confidentiality. Select all that apply. The physician keeps open the client's record. Sorry, open is double while talking with the client spouse. This is a violation of the confidentiality. If you are going to stop working with the records in a chart, physical chart, or a computer, and you are going to do other activities, are going to talk to somebody, you need to close the client's chart because, okay, we can read on it. Okay. How many times I, as a client, as a patient, okay, read in the records of other clients in the dentist, in the doctors, etc., because they forget to close the chart of the previous client. Two nurses discuss a client condition on the whole. The whole is not placed to discuss client details. It is a violation of confidentiality. A nurse looks in an assigned client's electronic record for history of drug use. This is if the client is assigned, and here is assigned to the nurse, is okay that looks any kind of information that consider is pertinent for the care of the client. This is no problem. A nurse check the record of a past client to see his or her evolution. This is violation of the confidentiality. Once the client is not your client, you don't have the right of looking in the chart of the client to find interesting information for you. This is not correct. A nursing student presents a case of sexually transmitted infection to the instructor, the client on FTI, no problem. It is correct because it had been assigned to the student. Okay, this is not a very easy to carry out. Okay, case. I preferred to discuss other clinical case with you. The age is a 38-year-old woman who comes to the labor and delivery unit having painful contractions. Sorry. The nurse takes her to the examination room and asks her the initial question to determine the next course of action. What are the three, they are limited to three, most important initial questions that will be asked before examining the client? So I have frequency of the contractions, intensity of the pain in scale 0 to 10, date of the last menstrual period, family history of diabetes mellitus, previous gestation and birth, history of hypertension, loss of vaginal fluid. So take in consideration that the way this is presented, the only information they are giving to us is that the woman has this age, that the woman is pregnant, and the woman is having contractions. Yeah. So we don't have any other information. Okay, I'm evaluating this because it's a clinical case that I wrote, and I want to discuss that with you to detect mistakes. So there is a mistake here. I should say that is pregnant. Just a moment. I have patience with me. Pregnant. Okay, I need to add this word. Those are clinical cases that I'm constructing. Okay, so the three most important questions. So I need what is important for me to know in this woman that is in labor because she's having painful contraction of the uterus. Okay, I need to know the age of the gestation because if the age of gestation is between 38 to 42 weeks, is okay to have contraction because it's the time of the birth. But if the time of the pregnancy is less than, it is defined like 37 and 5 days. Okay, the term. Okay, it is a premature birth, and it's important. So I consider that I need, as a priority, have limited to three most important questions. I need the date of the last menstrual period to calculate the age of the pregnancy. The other important factor in a client that is pregnant and is in labor is which one are the obstetric history of the client. Is her first pregnancy, the primipara, the first pregnancy, behave different from the multipara. So from the multipara. So Notice that I'm talking about the interview. So information that is going to be obtained from the client, okay? And information obtained from the client, okay? In interview. So I'm going to add this word to make it easier, okay? That's why I like to discuss the cases that I write to see if you are understanding. Okay, so the other information that I want in the interview is to know how many children had before, how many births had before, if it's primipara, multipara. I think this is the other important, okay, information to have an idea if I'm dealing with a primipara or a multipara. It's very different, okay, the management of the primiparas and the multiparas. And the other important information that I like to know, what is coming out from the vagina, because what I could be having coming down out from the vagina. First, nothing. It is possible, very possible. Nothing is coming out through the vagina. But what else could be coming out through the vagina? One, the bloody show, this mucus plug that is eliminated, which is normal, but also could be blood. The blood can be bright red or can be dark. And it could be important to diagnose hemorrhage of the third trimester, okay? Or maybe the client is leaking, is eliminating amniotic fluid through the vagina, which translates that the client has already spontaneously have a rupture of membrane, yeah, which is important. So this is three information that for me is very important to obtain from the client. The frequency of the contraction is going to be determined by myself, not by the client. I'm not going to ask the client how frequent are the contractions. I'm going to determine that myself, not in the interview, but in my assessment. The intensity of the pain is important, but we know that the intensity of the pain is going to be intense. Labor is very painful. The intensity of the pain in labor is not defining specific problems. You understand? So it's going to be very painful. And the pain is going to be intensifying progressively. Past medical history, like, for example, family history of diabetes and personal history of hypertension, are important information, but are not so definitive as knowing uh, the time of the gestation, the obstetric history, which is very important, and what is coming through the vagina. So that's why I think that those are the three most important data I need to obtain from the client as soon as possible, because it's just a client that is arriving in labor. I like if any one of you want to make a comment or objection of this, I like to hear from you.
Professor, so I think this is in this particular case in which we really don't have much information about them. They just showed up. We don't know anything. So that I agree with you.
This is
That
the initial to know what I have, and now
yeah.
I continue with the the other aspects of the interview. Okay, let's see this other question that I add to this scenario. The client last menstrual period was July 10th. If today is April the 3rd, calculate the age of this pregnancy in weeks. So how I would solve this? Trying to think a little, because you can have this question in your Nclex. So you know the Nagel rule. In the Nagel rule, the correct way of doing that is first writing in numbers the month and the date, the day, no? And then subtract them 3 months to the month. So it's going to be 4, no? And adding 7 days, okay, to the day. So it's 17. So what means April 17, this calculation, no? This calculation, there is an Nagel rule. This means the moment in which the woman arrived to the 40th week of gestation. So it is important to be knowledgeable, to know that the Nagel rule, this calculation that probably everybody knows, is to know when the woman is going to have 40 weeks of gestation. If at this date, okay, at this date, April 17, the client has 40 weeks, and today is April the 3rd, so 17 minus 3 is going to be 14. How many weeks I have in 14? 2 weeks. So subtract 2 weeks to 40. The lady is having 38 weeks of gestation. Everybody understood the calculation, or you want me to repeat that?
Understood.
Looks like everybody understood. Okay, in my experience, this type of calculation has been previously in Nclex. The age is the name of the woman. Report 3 pregnancies, including this. Twins born at 37 weeks and a miscarriage of 11 weeks. Determine how many gestations and paras are declined. Nclex only ask for gestation and paras when they ask that. They don't ask you for how many abortions, how many alive babies, and it is not so detailed. Gestations and paras. So obviously, this gestation is one. The gestation of the twins is another, and the gestation of the miscarriage is the other. So this is 3 gestation, 3 gesta. Okay, but this woman has only has one para, the twins, because the other one was a miscarriage, and this one has no, be born to again. So one para. Everybody agree? Okay. Could be another
Yeah.
question. Another question. The age had an uncomplicated pregnancy with regular prenatal care. Now we find more information, denies history of hypertension, diabetes, or allergies. The only fluid lost through the vagina was the mucus plug with a stria of blood, the bloody show, which is expected in the beginning of the labor and is a term labor in a multipara. Okay, in a multipara. The client has contractions 2 to 3 minutes apart. So every 2 to 3 minutes have a contraction, a good frequency, lasting 46 seconds. Okay, we have until 90 seconds. Okay, of safety. So still probably this woman is not in a very intense labor. Probably is in the active phase, okay, of the labor, still not in transition or in a second stage. Leopold maneuver confirmed one fetus in cephalic. Cephalic is the head is down, the dorsal of the baby is to the right. This is the application of the Leopold's maneuvers. To know, well, can help you to know is there more than one baby? Yes, if you palpate more than 2 heads, it's more than one baby. And especially when there are no resources, okay? We are spoiled by the ultrasounds and the um, over care of that we see in those times in the cities. But America have rural areas, and the rural areas you can be working as a nurse and there are no doctors nearby, and you can be in the predicament of having a non-controlled pregnancy of a rural area. Okay, and you can be using your Leopold maneuver to know what you have at hand. No? So it's only one baby, it's cephalic, and the back of the baby, the dorsal of the baby, is to the right. Point where you should auscultate the fetal heart tones. So we have A, B, C, and D. If they say that it's cephalic, okay, obviously the back is going to be is going to be is going to be me cuesta trabajo dibujar esto al revés. Okay, is going to be here. Yes, the back is going to be here. Okay, this is okay, the hand. Okay, and this is okay the baby. Okay, so the back is going to be here. So cephalic is going to be explore the fetal heart tone below the umbilicus. Yes, and if they say that the dorsal is to the right, you are going to place the stethoscope here to hear the fetal heart tones, okay, in this quadrant, in the quadrant C, okay, to hear the fetal heart tones. So it could be also an Nclex question. Remember that you are supposed in the huge belly of a pregnant woman at term, in this huge, okay, football field that you have there, in which part you place or you look for the fetal heart tones, because you cannot be randomly auscultating all the atoms, because you are going to spend the rest of the day doing that. You need to target the quadrant of the abdomen where the fetal heart tone should be found. And the base of that is to understand that you auscultate the fetal heart tone through the back of the baby. If the baby is cephalic, it's going to be below the umbilicus. And you need to know what is the back, to the right or to the left. That can be known by the Leopold maneuvers, or when the doctor tells you, oh, this is a right occipital anterior baby. So if it is occipital, it's because it's cephalic, and right R is at the right. You don't care if anterior, posterior, because you know it's just a little anterior or a little posterior, but in this quadrant, in this quadrant. Okay. Um. So it is. If they say, oh, the client is right sacrum, okay, anterior, posterior, then you need to know that the baby is sitting. The baby is sitting, and the back of the baby to the right. So you need to look for the fetal heart tone in the back of the baby, in the above the umbilicus on the right. Nevertheless, in my experience, Nclex babies always come encephalic. In reality, uh, almost 80 or 85% of the babies come encephalic. The big majority of the babies come encephalic. Okay, so it is another question that they can do in a clinical case of OB. Upon vaginal examination, the age is 80% effaced and 4 centimeters dilated. Okay, so remember that the cervix is like lips that protrude in the vagina. Yeah, that protrude in the vagina. And as the uterus starts the contraction, will pull those lips in this direction, flattening, okay, flattening the lips. And this is what is called the effacement, no, the effacement, okay, the effacement. And so there is an 80% of effacement. So only 20% of um, of, of cervix is protruding, and the opening is 4 centimeters. Okay, uh, can reach 10 at the end. The heart rate is 150, which is normal, no? Because okay, we have between 120 to 160 is normal and regular. She is admitted to labor and delivery room. Okay, knowing that this data in which stage and which phase is the woman. The woman is in the first stage, okay, because the first stage is going to last until the woman reaches 10 centimeters of dilation, when it starts the second stage. And the first stage is very long. That's why it's divided in 3 phases. okay, the latent, where the contractions are more distant and less intense, until the woman reaches 3 centimeters of dilation. So what defines the phase is the amount of dilation that reaches the opening of the cervix. 0 to 3 centimeters is the latent phase. So this is not the latent phase. From 4 to 7 centimeters, this is the active phase, where the contractions are more frequent, a little more intense. So this is, okay, active phase, because it has 4 centimeters of dilation. 8 to 10 is the transition, because it's going to have a transition from the first stage to the second stage. Transition. In the transition, the contractions are very intense, very frequent, okay, and very intense. Okay, very good. So it is a stage 1 active phase. Remember that stage 2 is when the baby sinks, beginning at the 10 centimeter dilation and ends when the baby is totally out. The body of the baby is totally out. The third stage, when the placenta comes out. And the fourth stage is the period of observation of the woman in the postpartum, especially monitoring for bleeding. What nursing measures should be taken at this time? Okay, so the woman is in labor, is in first stage. What should be done with a woman, okay, in this condition? So it's have 4 centimeters, the baby is stable, the ¿cómo se llama? The membranes are intact. What we can do? Clear liquid diet. Yes, women in labor can have clear liquid diet. You need to know what is clear liquid diet, because they can add in there more specific. Can have milk, can have ice cream, can have Coke, can have tea, can have apple juice. What is clear liquid diet? Okay, you need to decide what can have the woman. Notify, or the doctor, obviously, if the systolic blood pressure is more than 140 or less than 90, or the diastolic blood pressure is more than 95 or less than 50. I found this in the protocols of a hospital, okay, of OB, and I like it, because they tells you more or less to educate a little you when the blood pressure is high or is low, because the normal blood pressure is neither high or low, and this client can have as a complication in labor. A laboring woman can have a complication either one, high or low. So systolic more than 40, 140, okay, diastolic more than 95, but low systolic less than 90, diastolic less than 50. I found this useful. It's a good protocol. So I wanted to share that with you. So that's why it sounds okay. If I were in my Nclex and I didn't remember or know the parameters, when I see that, I say, it is okay. Notify if the blood pressure is high or low. Okay, it is okay. I'm going to mark this because it's okay. Rest in bed is not necessary. In this stage of the labor, the woman can ambulate. So there is not obligation of having rest in bed. And for that reason, the woman has bathroom privileges. What means that the woman can walk to the bathroom to pee. Why? Because the dilation is still small and the membranes are intact. Okay, so the women are allowed to ambulate. Insert Foley catheter. There is no need of insertion of Foley catheter in a woman in labor. It's important to make the woman pee every hour, every 2 hours, because it's important to keep the bladder empty during labor. It favors the advance and the descent of the presenting part, but there is no need of being invasive with Foley. If the woman is going to a C-section, then it's necessary to have a Foley catheter because the urinary bladder need to be totally empty, okay, during a cesarean section. Start a peripheral venous access device with saline lock? Yes. You cannot have a woman in labor, even if it is an uncomplicated labor, without having a vein taken. A saline lock doesn't require an IV fluids and a tubing connected. You know, the saline lock allows to have the catheter permeable patent without the need of an attachment of the IV. It is necessary for just in case. And monitor the fetal heart rate every hour is wrong. The monitorization of the fetal heart rate should be more frequent, ideally continuously. That's why in 1 hour, a fetus can die. And monitoring the fetal heart rate every hour is too separated. So sorry, it is a no. It is incorrect. You don't mark this. Okay. Okay. Perfect. So do you agree with the interventions? Okay.
Yes, sir.
Okay. Find something to add. Help me to build the clinical scenario. The nurse reviews the client blood work. Okay. And so here is the blood work. Okay. I stole a blood work from a client that is and modified some parameters. Um, Hematocrit 34, hemoglobin 12. Okay, it is a normal hemoglobin. The client is not having anemia. 3 times 32 is more or less. There is no dehydration, so it's okay. White blood cell counts. Okay, what do you think about this white blood cell count? Okay, what we should know is that when a woman is in labor, the white blood cell count increases normally and can increase as much as 20,000, 25,000. And this leukocytosis that appears during labor persists in the first 24 to 48 hours after birth. So leukocytosis is an expected normal finding in a woman in labor. Take care, because if you don't remember that, then you make a mess for those white blood cells, which is a normal finding in this woman that until now obviously has not any infection that uh, uh, brings concern to us. This is an expected finding. Okay, so it is a good to remember. The woman is ORH negative. It is super important. So we need to know because this woman have previous pregnancies. Yes, we need to know if this baby, the one that is going to born today, is coming affected by this fact. So it is going to depend mainly of what happened in previous pregnancy. She had 2 previous pregnancy, 1 miscarriage and 1 twins, gestation. What happens there, we don't know. Maybe we ask the woman, did they give you ¿cómo se llama? The Rogan, okay, in previous pregnancy. Maybe the woman is not a nurse, is not a person who knows, they gave me a lot of shots. I don't remember the name of what they gave me. Maybe the woman knows, maybe doesn't know. So we need to make or anticipate, the doctor need to make objective, okay, if the woman uh, was protected from developing antibodies against Rh positive, okay, in that could brings problem in subsequent, okay, pregnancies. You should know that the way of knowing that is practicing a woman the test Coombs. So if the woman is negative, Rh negative, a Coombs should be done. What is the test of Coombs? It's a test to demonstrate the presence or not of antibodies against Rh positive red blood cells. If the Coombs is positive, it's because the woman already has those antibodies. And this baby is coming with problem because those antibodies should be attacking in this moment the red blood cells of the baby if the baby is Rh positive. But we don't know the blood group of the baby, you know, and we don't know who's the father. Okay, so it is not important what group is the baby. It is not important who's the father or what group is the father. What is important is that the woman is Rh negative and we need to explore Coombs. If the woman is Coombs negative, means that she was protected in previous pregnancy with the Rogan, and or the babies that she had before were not Rh positive. Those are the possibility. So in two words, what is important for this woman is to practice a Coombs test. A Coombs test to know if she is, if this baby is coming with problems, because remember, the one that with the problem is the baby. And second, to know it is worthy to give this woman the corresponding dose of Rogan within the 72 hours of the birth. The Coombs test has two laboratories techniques. One is the direct Coombs, and the other one is the indirect Coombs. When the Coombs is done in the mother, is indirect. When the Coombs is done in the baby, because after the baby is born, after the baby is out, yes, I can take a little amount of blood from the baby, a drop of blood from the baby, and do my Coombs test in the baby to see if the baby has in his or her blood the antibodies that we were commenting against Rh positive red blood cells. And in the baby is direct, comes direct. Okay, so this is just a laboratory technique, which is different in the mother and in the baby. Okay, the white blood cells, okay, have predominance of the neutrophil because it's found also in labor, and of course the others are comparatively low because it is a proportion. This is a percentage, so it is, as I said, the white blood cells is not a good guidance, a good reference to diagnose infections during labor and the immediate postpartum because in all women normally are elevated. Platelet count is important, which is very important because in pregnancy, remember, there is a lot of incidence of disseminated intravascular coagulation as complication of the pregnancy. So thanks God the platelets are okay. It's one of the factors that drops sooner in disseminated intravascular coagulation. Sodium is okay. Incidence is a little low. Okay. Potassium is okay, but not important. The chloride is normal. The carbon dioxide is normal, a little low, maybe she's hyperventilating. Anion gaps is okay. Anion gap is a test that is not frequently tested in Nclex. Anion gap elevates when the client is developing metabolic acidosis, when you are producing acids, abnormal acids in the body, like for example, lactic acid, keto acids, etc. Those are anions, okay, anions, and then appears an anion gap, okay, and it is not important in action, so don't worry too much about okay anion gap. Uh, the BUN is okay, bilirubin is okay. Okay, the bilirubin in the mother doesn't elevate when there is problem of RH, isn't the baby. Okay, don't get confused. Very good. So, what laboratory test? Ay, mira, le dije la respuesta. What laboratory test does the nurse expect to be ordered before deciding intervention related to the maternal type of blood, fetal blood type, indirect CUMS, spouse blood type, direct CUMS? Is the indirect CUMS need to be done in the mother? We cannot do still not. We still cannot do the direct CUM because the baby has no born, and we don't do that in the spouse because we are not in this moment in the situation of deciding who's the father. It is nonsense. um, and of course the fetal blood type, the same as the direct comes, need to wait until the baby is out. Okay, so this is your understanding of the management of that. While observing the labor monitoring register, register, the nurse observed the following image. The nurse observed the following image. Okay, observe the following image. And then I have the image here. So it is the contraction. So this is the contraction, okay? And this is the fetal heart rate. Uh, this level is 120. Okay, let me see if I can, have, okay, pulse to that. And this is 150, 160, 170. And this is 160. Okay, this is 160. So those are the limits of the normality of the heart rate. Yes, are you agree? 120, 160. So as you notice, most of the time, the heart rate of the baby is between 120 and 160. But from time to time, there is a drop. There is a drop to okay, of the heart rate below the accepted as normal. When this occurs, when there is a drop of the heart rate, we call this deceleration. But we need to discriminate, we need to tell apart which type of deceleration the client is presenting. In this case, we are going to compare the momentum of the deceleration with the momentum or the moment of the contraction. And then we are going to notice that they are a mirror image. They are totally opposed. If you put a pen here, they are coincident. When the top of the contraction image is coincident with the lowest part of the deceleration, we call this early deceleration. Early deceleration don't have pathological implications. It's a physiological response of the baby during the contraction. The contraction produces or triggers a vasovagal reflex that produces the deceleration. So the ones we diagnose, because the aspect on the chronological coincidence of the deceleration with the contraction, we diagnose this and early. What we do is continuing the observation, the monitoring of the labor, because this early deceleration recovers spontaneously and don't require any intervention. Don't need to be reported, don't need any intervention. Okay, so the intervention that should be taken is just continue, okay, the monitoring. There is no need of any other intervention. Okay, later I fix it. The age state that she is feeling discomfort and asks whether there is an alternative therapy for pain before taking medication. Many women would like to have her labor and birth without medication, without analgesics. It is something that, for several reasons, some people prefer. This lady is asking for non-pharmacological, non-medication intervention to appease, to alleviate the pain. So the question says, list 4 non-pharmacological methods the nurse can provide to assist the age with controlling her pain. We have acupuncture, movement on a birth ball, butorphanol, which is a medication. Butorphanol is a partial agonist opioid. So we rule out that because the woman doesn't want, at this level, medication. Abdominal effleurage, okay? Counter pressure on sacral area, guided imagery. Acupuncture is not in the scope of practice of nursing. Acupuncture is considered an invasive procedure. There is penetration of the skin and is not in the independent, okay, um, um, uh, independent nursing intervention. So obviously we are left with 4 okay options. What is the movement on a birth ball? Those are big balls, plastic balls. The woman in labor, okay, in the early stage of the labor, okay, is going to sit in the bowl, okay, is going to sit in the bowl, and the woman is going to be making, okay, movement, okay, rolls, okay, of the pelvis, okay, in the bowl, and this is going to facilitate, okay, the descent of the baby, and is going to produce, of course, distraction, a distraction, okay, a distraction of the pain. Is non-invasive, is frequently used. The abdominal effleurage is massage that the nurse can do a very light massage that can be done in the abdomen, okay? Massage that can be done. So effleurage is massage, it's the same as massage. So is mild massage that is done in the abdomen that also, help, okay, the woman alleviate. Remember that when we are producing uh, tactile stimulation, etc., this is distracting the brain of the pain. So the pain is traveling through the spinal cord, through this via, but also what we are doing is also traveling through the same way, and this is going to interfere, okay, in the transmission of the pain. So it is okay. Counter pressure is when the contraction comes, you can make pressure here in the sacral area. The woman that is having labor feels that the sacrum is, tearing apart. There is an intense pain there. If you make pressure here, the woman usually refers some relief doing this pressure in the sacral area. And guided imagery is when you stimulate the person with pain in thinking in something that is especially nice, a memory that is especially comfortable to remember for the client, which is going to produce endorphins and is going to produce improvement of the pain. So uh, I bring this because lately, not lately, I remember having this question in my anchors, and I took my anchors like 20 years ago. Uh, but lately, Nclex is having this kind of non-pharmacological interventions very frequent, tested. And so some people don't know what is this. This is massage, okay? And some people don't know what is that. I knew this because it's very commonly used in OB. Guided imagery, of course, is when you are thinking you are in the beach, you are in, in your preferred place, and you are thinking in other very nice stuff instead of being concentrated in the suffering of your pain. And the birth ball also is frequently used by the doulas. Okay, 3 hours later, the ace is lying on her back, which is no good. And you notice the following pattern during the fetal heart rate monitoring. So now the monitorization shows a last lack of coincidence of the deceleration, because this is a deceleration, yes, in relation with the contraction. So obviously now the deceleration is happening late, is happening after the contraction. So now this is a late deceleration. It has a totally opposed meaning. This is an emergency. This translates a severe fetal distress. It translates that the placenta, for any reason, is dysfunctional and is not providing enough oxygen and blood flow to the baby. And for that reason, the baby is in distress. So it requires immediate intervention, requires immediate intrauterus resuscitation is called, uh, because it's very serious. Uh, um, you stay with the age when you notice this and call for someone to notify the healthcare provider, the PCP. Put in order of priority the following interventions here are all here. So what is the first that you do? The first that you should do is to stop the contractions. The deceleration occurs each time a contraction comes. When there is not contraction, there is no deceleration. So the big distress is happening when the contraction happens. So you need to stop the contraction. And the woman is receiving oxytocin because it's stated in the ¿cómo se llama? In the question. So the first that you should do is to stop the oxytocin infusion. It is a common situation in different scenarios of other scenarios. For example, a client receiving IV fluids or just IV fluids or a transfusion and is developing pulmonary edema with the IV fluid or an adverse reaction with the transfusion. What is the first that you do? Stop what is producing the problem. Stop the IV fluid, stop the transfusion, stop the oxytocin. No doubt that is the adequate. Okay, there are many question banks that can confuse you in this aspect. Has been well reviewed. The first intervention is to stop the oxytocin. Immediately that you stop the oxytocin, that is just a second or less than a second. Okay, it takes less than a second. You need to turn, okay, the client from the supine position that was having to the left lateral position, okay, to left side. You can even elevate the legs. Why we do that? We do this with the purpose of increasing the cardiac output or the volume of blood that the left heart of this lady, the age, is pumping. Why? Because we want to send more blood with oxygen to the placenta, increasing the cardiac output. Okay, more blood arrives to the placenta and the fetus is going to benefit. How I can increase the cardiac output? Turning the client to the left side. Why? Because this way we decompress the inferior vena cava that is compressed by the gravid uterus when the client is supine. When more blood returns because the vena cava is not compressed, more blood is returning then um, uh, to the right heart, more blood, okay, after oxygenation is going to leave the heart. So the cardiac output is going to increase. If we elevate the client legs, okay, at the same time that we turn the left, we are also, you know, increasing the cardiac output because we increase the blood return. The blood that usually is pulling in the veins of the legs is going to be returned to the circulation. So that's why the second intervention. Then we want to increase the amount of oxygen that this blood is transporting. So the third intervention that we should do is to initiate oxygen, but at very high doses. Do you remember that some nursing students say that nurses cannot give more than 2 liters per minute and are wrong? At least I insist in correcting those misunderstanding of nursing students. Nurses can initiate any amount of oxygen as far is indicated in the client. Not always oxygen is good for the client. Nurses need to know when oxygen is good and when it's not good. And clients need to receive the adequate amount of oxygen. In this situation, the amount of oxygen is very high, 8 to 10 liters per minute by face mask, no through nasal cannula. And they are giving us the possibility, the option of increase the rate of IV fluids, the maintenance IV fluids, to increase the cardiac output. And it's okay. This is the last to be done. Okay, so this is the order. There is a mnemonic in textbooks for this, and it's stop. Stop. So stop the pitocin, turn, decline, give oxygen, and call the physician. We already have, okay, in this previous statement, notify the PCP. What we anticipate if this late deceleration is not corrected, that the client will need an intervention for the part of the PCP to take this baby out as soon as possible. If the baby is already almost out, then they can use forceps. If the baby is still high, then they can decide a C-section. That's why the PCP need to be notified. While turning the client, you observe a gush of greenish amniotic fluid coming out from the vagina, followed by the structure observed in this image. So what you think is this? The umbilical cord. So uh, uh, as you notice, the situation is becoming complicated. So in the moment that the baby is showing this distress, the woman have the rupture of the membranes. The amniotic fluid has abnormal color because this is not the normal color of the amniotic fluid. The color of the amniotic fluid is the same color that you see, for example, when you take rice and you add water to the rice. This color that acquires the rice water is the normal color of the amniotic fluid. A brown or greenish amniotic fluid means that the baby is pooing inside the uterus, and the liquid is mixed with meconium. It's a meconial liquid. And it translates, when the baby do that, is because the baby is in distress. It's a manifestation of baby distress. uh, any aspiration from the baby of this meconial fluid can produce atelectasis in the lungs and even can complicate the postnatal, okay, evolution of the baby. So it's not good to have this. And then you have obviously a cord prolapse. The umbilical cord is prolapsing through the vagina. So the question say, which intervention does the nurse anticipate taking when observed and diagnosed, and the doctor has not yet arrived, is coming, okay, observing this cord prolapse. So you are going to have the following options. Position the bed in Trendelenburg position. This is correct. You have two options as a non-specialized nurse in this situation. The two options that a entry level registered nurse. Nclex is an entry level registered nurse, okay, situation. What the RN can do is either place the client, okay, in the niches position, okay, in the niches position, okay, the niches position. So it's going to be, okay, in the, okay, in the, in the mattress, in this niches position, yeah. The woman is going to be in the niches position, or very simple, with the woman that was already turned to the left. The woman was already turned to the left, no? So was already resting, okay, to the left, okay? So you are going, okay, to put the bed in Trendelenburg position. Okay, so uh, 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 the Trendelenburg position. So you elevate the legs of the bed. The bed, a clinical bed can do that. And the purpose is to move the baby to move away of the umbilical cord to reduce the compression of the presenting part in the umbilical cord. The same, the same is happening if you move the client to the Trendelenburg position. So you can have in your test either knee chest position, if the woman can adopt this position, or Trendelenburg position of the bed. It's doing the same. Uh, I know that you have been in books, etc., that a hand can be introduced in the vagina, a hand or fingers can be introduced in the vagina, and you can push the presenting part away from the umbilical cord. Okay, entry level registered nurse are not trained to do that. The one that do this is the MD, is the doctor. So there is an option here, is offer the doctor, the PCP that arrive, clean gloves to push the fetal presenting part. Nevertheless, um, I make this too complicated, too tricky. Clean gloves should not be used, should be used sterile gloves. Why sterile gloves? Because the umbilical cord is protruding, and because the membranes are already broken. So the ideal is to say sterile gloves. So now the PCP can't introduce the fingers and push the presenting part. If any of you are in this situation and introduce your fingers in the vagina, you are not going to differentiate what is the presenting part, what are the walls of the vagina, what are the cervix, and what is the umbilical cord. And maybe you are going to be pushing something that you could not push. You understand? Especially the umbilical cord cannot be pushed. That's why this maneuver that is very effective, but cannot be done by the RN, the entry level RN, is done by the PCP. Okay, with sterile gloves. Okay, with sterile gloves. Okay, insert Foley catheter and transfer to the OR. It is correct. This client with the umbilical cord prolapse needs to go for a cesarean section. Clean the umbilical cord with chlorhexidine and wrap with moist sterile gauze. You don't clean the umbilical cord with chlorhexidine. Cannot be cleaned. You can wrap with moist sterile gauze, but the cleaning with chlorhexidine is not necessary. It's not convenient. This umbilical cord cannot be, treated with chemical substance because it still is working. Initiate magnesium sulfate infusion. The woman is not describing having risk for seizures or preeclampsia. There is no need of that. So uh, position in Trendelenburg and prepared for an emergency C-section would be the two interventions that you mark in a similar question. Client is taken to the OR for an emergency section, obtaining a term newborn with Apgar 5 at 1 minute of birth. Which intervention should the nurse anticipate helping the newborn into the transition from uterine to external life? So the baby 1 minute at the moment of birth is Apgar 5, so is depressed. Okay, what kind of interventions are required with Apgar 5? Okay, spank the buttocks to make the baby breathe? No, we don't do that nowadays. I don't know if you saw that in movies, etc., but we don't do that nowadays. Suction the mouth and then the nose is correct. Why? Because the baby will be breathing through the mouth through crying. Rub, I know that is boring, but if you mute the microphone, nobody is going to know that you are bored. Rub vigorously while drying the skin. This is in the Nclex question. This is the way of the equivalent of the spanking is the vigorously rub, okay, the baby at the same time that you are drying the baby to prevent hypothermia. Initiate chest compression is not necessary. If you have Apgar 5, okay, this baby is having more than 3. Um, um, when the baby is Apgar 0 to 3 is when the baby needs CPR, cardiopulmonary resuscitation, including chest compression, intubation and chest compression. When the baby has Apgar between 4 to 7, what needs is rubbing, drying, and aspiration, suctioning, and oxygenation. Okay, Apgar 80 or more doesn't need any special intervention. You put the baby with the mother. So no need of chest compression. Administer oxygen 6 liter per minute. Yes. Through no, through nasal cannula.
No
No,
profe
babies don't
cannula.
use. Yes, they don't use nasal cannula. So it is no. Okay, it is another. I'm trying to reproduce here question that have been recently in English. No nasal cannula in babies. And the last, prepare for endotracheal intubation, not necessary. When you have 5, there is no need of endotracheal intubation. The endotracheal intubation, 0 to 3. Chest compression, 0 to 3. Yeah. 4 to 7, stimulation, suctioning, and oxygen. And 8, just put with the mother. Doesn't need any specific, intervention. Okay, so uh, okay, to practice, okay, what to do with this, okay. 5 minutes after intervention, the newborn has Apgar 8, so this is what happens from the minute 1 to minute 5, if the interventions are correct. The baby, improve and is transferred for neonatal intensive care unit because it's a baby that has been in distress with meconial liquid, etc. The mother is moved to the post-anesthetic care unit for recuperation. While checking on the age 1 hour after delivery, you observe a small amount of blood in the perineal pad at the level of the vaginal introitus. Which intervention should the nurse take next when you are checking her 1 hour later and you see some blood in the perineal pad? Remember that when you check the perineal pad, those are the client buds. Okay, this is the perineal pad. Okay, the perineal pad. Okay, this is the perineal pad, and then you notice that there is blood, okay, in the perineal pad. This is more or less because you lower the perineal pad, to see the perineal pad, and then you return the perineal pad in position. Yes. What you need to do next, if you see that, document the finding and continue observing, massage the uterine fundus, check under the DH buttocks, and request an order for phytonadione intramuscular. Phytonadione is vitamin K. Okay, the vitamin K need to be given at the baby, not necessarily to the mother. The recommendation to be done in this case is that you need to check under the buttocks of the clients because for bleeding is not enough to observe the dressings of, in this case, the perineal pad. You need to explore with globes under the client because frequently the blood is pulling behind the client, between the client and the mattress, and cannot be seen in a simple, okay, observation. The purpose of this question, and you choose C. C. They are not mentioning a boggy uterus, so no massage is necessary. There is no deficient vitamin K, and If there is no blood under the buttocks, then you document the finding because it's a normal amount in 1 hour, a normal amount of blood presence in the perineal gland. Your silence tell me that you agree and you understand. Okay. Okay, the nurse found more blood, okay, under the H buttocks and the uterus deviated to the left with decreased muscle tone. The H still has the indwelling catheter on. After reporting to the provider, which intervention should the nurse take first? Entonces, the nurse, when exploring behind the buttock, found a lot of blood there with clots. So there is blood there. So the woman is bleeding. But the uterus is boggy and deviated from the midline. It happens when there is a distension of the urinary bladder. But the woman, the age, still have the indwelling catheter on. So why, after reporting to the provider that the woman is bleeding more than normal 1 hour after birth, what intervention should the nurse take first? First is the critical word. So massage the uterine fundus, request an order of oxytocin, check for indwelling catheter for patency, have an intrauterine balloon available. Everything is correct, but what needs to be done first is check for the indwelling catheter for patency. Because if you are suspecting that a distended urinary bladder is producing the uterine atony, is because the catheter is obstructed or is having a kink, you know, and this is the first that you should be doing to drain the bladder, because when the distended bladder is the one that is producing the uterus atony, no matter how much massage you do, it's not going to contract. So this is the first to drain the urine, and then you do second the massage of the uterus. If it's not enough, usually doctors order oxytocin, a drip of oxytocin to make the uterus contract. The intrauterine balloon is a resource. It's like a Foley with a balloon, but bigger, no? That can be inflated inside the uterus to make compression in the walls of the uterus when there is an atony that doesn't respond to this maneuver, and to stop the bleeding. To stop the bleeding is the uterine intrauterine balloon. Was relatively recent in one of the options in the in Nclex, in clinical scenario of postpartum hemorrhage. Okay, I move because I assume that that you're okay. Doctors order oxytocin 2 milliunits per minute IV. Okay. Pharmacy sends oxytocin 10 units in 1,000 milliliters of D5W. At how many milliliters per hour the nurse sets the pump. And then you need to do your calculation. Have different options. You calculate that by dimensional analysis. You calculate that by proportion, or you calculate that with the formula doctor's order available. So doctors is ordering 2 milliunits, okay, per minute. Yeah. And what you have available is 10 units. So you need to transform the 10 units in milliunits. So how you transform units in milliunits, you multiply times 1,000. So 10 times 1,000 is 10,000 milliunits is what you have. And in which amount of liquid? In 1,000. Okay, this is the formula. Doctors in the top, nurse in the bottom. Okay, and of course you do the calculation. So it is going to be 0. This is going to be milliliter, sorry, milliliter. So milliunits kills milliunit. So this is 0.2 is going to be 0.2, okay, milliliters per minute. But because you want to set the pump, You need to multiply this times 60, times 60, because an hour has 60 minutes. So it's going to be 12 milliliters per hour. And you can do that dimension analysis that is going to give you the same result directly, or you can do that by proportion. So this is a possible, okay, nursing question. For the people that is still at this level, continue with the math phobia. For these kind of questions, if you have math phobia, you are not at this level able to learn dimensional analysis or proportion, use the formula. Doctor in the top, nursing at the bottom. Doctors in the top, okay? MD. What is the MD ordering? 2 milliunits per minute. This is doctor order. What you have? The oxytocin that's in pharmacy, but 10 units. You cannot work with units and milliunits. You need to transform. So units are transformed in milliunits. Multiply milli means in Latin 1,000. Multiplying this 1,000. So now you have 10,000. 10 times 1,000 is 10,000. Okay, things in dollars. Okay, a milli units, and you have that in a thousand milliliters. You know that with a calculator you are going to obtain. You are going sorry here. You are going to obtain 0.2 milliliters, because milliunits is gone. It's milliliters per minute. But the pumps, because they say how you set the pumps, only work milliliters per hour. They don't work never per minute. So you need to transform this per hours. And to transform if you are giving 0.2 milliliters each minute, and the hour has 60 minutes, please multiply times 60. Yes? And then you are going to have 12 milliliters per hours, and you set the pump at 12 milliliters per hours when you hang this stuff that's sent the pharmacy. Okay, so very easy. It's very simple calculation that can be done without a calculator. Okay. After correcting a urinary catheter king and uterine massage, the bleeding stopped and the H vital signs were stable and the hemoglobin was normal. The client asked the nurse if the low emotional stamina she was experiencing was related to the loss of blood. The nurse explored with the client her knowledge about postpartum depression. Which client statement about postpartum depression requires follow-up? I will make an effort to talk with someone about my feelings if I start to feel overwhelmed. It is perfect, no problem, no need to follow up. It's common for women with postpartum depression to have delusions about the baby. You need to know what is the concept of delusions. Okay, we discussed that in the review of mental health. Delusions are crazy ideas, irrational thoughts in the mind, in the brain, inside the head, okay? Abnormal, irrational thoughts. Those thoughts can be, for example, as irrational as no, this is not the son of my husband. This is the son of the devil that impregnated me. This is, for example, a delusional idea, which can be, okay, something serious. No, so this is not expected in the postpartum depression. This is observed in the postpartum psychosis, which is something different, another diagnosis. Postpartum psychosis is a psychosis. Is very similar, very similar to the schizophrenia. Has very bad prognosis. It's not good having postpartum psychosis. Yes, and yes, there are delusions, okay, even hallucination, etc., in the postpartum psychosis. Now we are talking about postpartum depression, which is much more common and is has better okay outcome. So this is not correct. The other is women with postpartum depression can have feelings of guilt and worthlessness. You know, that is the characteristic of the depression, that you feel like a worm. Okay, yeah, worthlessness, decreased self-esteem, guilt, feel, etc. It is correct. Okay, no need of follow-up. It is a correct understanding of depression. I mean, I may experience postpartum depression up to a year after delivery. Yes, you need to know that the postpartum depression can appear very late in the postpartum year. Okay, so what needs follow up is option B, because this is not depression. This is something more serious. That's it. This is the purpose of this question. Squeezing the problem, the possible questions in a clinical scenario. The second day of postpartum, the age is doing well and instead she feels fine and is not experiencing pain. She's preparing for discharge with her infant. Her discharge orders are fetal sulfate, ketorolac, hydrocodone bitartrate, and acetaminophen, and follow up in 4 to 6 weeks. Which part of the discharge process could be appropriately delegated to the LPN working with the nurse today? So that apply. Reviewing with the client the signs of postpartum depression. Yes. So can you, the nurse, discuss and taught the client about what is postpartum depression? Can the LPN review, let's see, reinforce what the nurse told to the client? Yes or not? Yes, the answer is yes. So LPNs can reinforce teaching or topics already discussed by the RN. So if you teach a client, I don't know, how to use the incentive speedometer, the LPN can refresh, insist, remind, or reinforce the teaching that you already did. If you are having problems with delegation, uh, please do la charity. Remember that you have this book in your shelf book from the school. Okay, explaining the client the signs of dehydration in the newborn. Okay, so it is teaching, yes, because I avoid using the word teaching. I say explaining the client the signs of dehydration in the newborn. It is a new teaching. This should be done by the registered nurse. Ordering a breast pump for the patient. Why? Okay, so why are you ordering a breast pump for the patient? The LPN doesn't need to take those decisions. Suppose that the nurse and the mother or the lactation specialist conclude that is more appropriate for the woman to pump the milk and then give the milk in bottle. This is something that requires evaluation, assessment, evaluation, etc. Doesn't is not in the LPM scope of practice. Doing the final physical assessment of the patient before discharge, yes. Remember that the taking the vital signs and checking the clients before going home is an ongoing assessment. It's not the initial assessment when all those initial complications appear that should be done by the RN. Doing the final physical assessment is the ongoing assessment that can be done by the LPN. Discussing the contraception option for the client should be done by the RN. It's the same as the signs of dehydration in the newborn. Those are teachings and discussions that belongs to the RN, are initial. Weighing the infant and por supuesto que infant weight, una redundancia. Weighing the infant and reporting to the RN any weight loss on relation to the one at birth, yes, there is no problem. There is no problem. Doing umbilical stump care with alcohol, no, because alcohol is not used for the umbilical stump care. But umbilical stump care can be done by the LPA. Okay, so this is the last question that I created for this clinical scenario. Okay, so any suggestion, any doubt? Okay, are you okay? Safe.
Yes, Professor. Thank you very
Okay,
much.
so if you're okay, I'm not going to bother you more. See you next time. Next time is going to be Thursday because on Monday thing is not, no, the school is not going to be open. Okay, bye bye, guys.
Thank you very much,
Okay.
Professor.
Thank
Bye
you.
bye.
Thank you.
Thank you.
Okay, bye bye. God bless you.